Hello everyone. Today I will be discussing 10 frequently asked questions regarding hypertension. Especially I will discuss about hypertension in association with diabetes. This video is mainly for the beginners who wants to know how to start treatment in hypertension, how to diagnose it, what are the ways to measure blood pressure, and how to choose among various antihypertensive medications. So if you are dealing with hypertensive cases regularly, I recommend you to watch this video till the end so that you will have a proper basic foundation whenever you are initiating treatment for hypertension. So we will begin now. So why I have chosen hypertension in association with diabetes? Mainly because of the statistics. That is, the prevalence of hypertension is roughly about 50% in diabetics. In the sense, if there are 100 members who are having diabetes, about 50 of them will be definitely having association of hypertension. And we know that both of these synergistically increase the vascular risk, leading to myocardial infarction in about 20% of such individuals. And when it comes to stroke, the number is even more. That is, about 23% of these individuals will have stroke. Whenever both of these will come in combination, we have to be very, very careful. The second question, what will be the target blood pressure in diabetics? Remember, it is less than 130/80. Suppose the individual is elderly, for example, more than 70 years. Keep a higher cutoff of less than 140/80. Because there will be chances of orthostatic hypotension and all. So we can take a higher cutoff in elders. And in general population, according to various hypertensive guidelines, we will consider the individual as having high blood pressure if BP is more than 140/90. So this is for general population. Whereas if the individual is diabetic, we have to keep the target even lower to less than 130/80. Now, how to measure blood pressure in any individual to diagnose hypertension? There are various methods like office blood pressure monitoring, which we commonly do in the OPD setups and all. But the thing is, it is very prone to errors. That's what we call it as white coat hypertensions, which is seen in about 32% of the population. Whereas the other method is home blood pressure monitoring and ambulatory BP monitoring. In home blood pressure monitoring, we have to advise these individuals to take 2 readings at 1 minute interval each in the morning and evening. And this should be done for about 3 to 5 days or 3 to 7 days. And at the end, we have to discard the first day readings and we have to take the other day's average. And if it comes to be more than 130/80, as mentioned in the previous slide, we have to consider it as hypertension. Whereas in ambulatory, it is considered as gold standard method for the measurement of blood pressure because it is able to detect even masked hypertension. So by using this particular way, about 66% of diabetics who are considered as normotensive will turn out to be hypertensive. That's why this is the gold standard method. So these are some various measures for blood pressure recording. And whenever an individual visits your OPD or clinic, what are the things which we have to follow when measuring blood pressure? We can use a validated electronic device and the cuff sizing should be proper because the disproportionate size of cuff will lead to abnormal blood pressure readings. So this point should be taken care. Then initial measurement at first visit, we have to measure blood pressure in both the arms. Suppose there is any discrepancy by more than 10 mmHg, we have to take it as abnormal and we have to work up for arterial disorders. And some environmental conditions like the room should be quiet and there should be comfortable temperature. Also advise the individual not to smoke or not to take coffee or any medications or doing exercise minimum 30 minutes before the measurement. And once the patient is ready, they should be seated and relaxed for 3 to 5 minutes before measurement, and patient should sit with their back supported by the chair. Legs should be uncrossed, feet should be flat on the floor, and the bare arm should be resting on the table with the mid arm at heart level. So these all things should be taken care when measuring the blood pressure in that particular individual for the first time. And during measurements, there should not be any talking, which we often do in the OPDs, like we will be taking the history meanwhile measuring the blood pressure. Ideally, it should not be done. And for the first time, if you are doing this, take 3 readings, 1 minute apart, and then we have to take the average of last 2 readings. So all these things should be followed when it is office blood pressure measurement. Whereas at home, as I mentioned, for home blood pressure monitoring, advise them to take 2 readings in the morning and 2 readings in the evening at 1 minute gap. And this should be done for 3 to 5 days or 3 to 7 days. And when they get all the readings, we have to discard the first day values and we need to take the average of other days readings. And if it comes to be more than the target, for example, more than 130/80 in diabetics or more than 140/90 in general population, we should consider it as hypertension. Then the fourth question is, okay, now in this diabetic individual, we have found out that the BP is more than 130/80. So we are considering as having associated hypertension. So what should be the first line agent in treatment? So always choose RAS inhibitors, either ACE inhibitor or ARBs. Commonly we will go ahead with ARBs. So this is the answer. What about add-on therapies? So remember, calcium channel blockers or thiazide diuretics should be utilized as second line or add-on agents. So what is better? Using single group of medication or combination? Remember, combination therapy is always better, especially if the individual is having any comorbidities like renal disorders or cardiac dysfunction. Even in these individuals which we are discussing, that is diabetes plus hypertension, we can start with combination therapy, which will be even more beneficial. So the combination which is preferred as first line strategy is RAS inhibitors plus calcium channel blockers. So why this combination? Because this will target dual pathways and it is renoprotective and there will be better adherence. And there are few things like what should be avoided as a first line strategy, especially beta blockers and diuretics. Okay, what about beta blockers? Remember, try to avoid them as first line agents for hypertension therapy in diabetics and reserve these particular drugs for those who are having associated history of heart failure or post myocardial infarction, because as we all know, there will be high chances of masking the symptoms of hypoglycemia in diabetics. That's why better to keep these drugs for only reserved cases. Now we got to know about the few important points about various groups of medications. Now how to start the therapy? So in this flowchart we can clearly see if the initial BP is between 140/90 and 160/100, in the sense if it is less than 160/100, we can start with one agent and always look for albuminuria. If there is presence of albuminuria, that one agent should be RAS inhibitor, either AC inhibitor or ARB. If there is no albuminuria, we can choose any of the 3, either RAS inhibitors or calcium channel blockers or diuretic agents. But ideally, even in that case, AC inhibitor or ARB should be the first choice. Suppose the individual is having initial BP as more than or equal to 160/100. In that case, ideally better to start with 2 agents. So again here we have to send for urine routine to look for albuminuria. Suppose there is albuminuria, among these 2 agents, one should be AC inhibitor or ARB without fail. And with that, as we are starting combination therapy, we can choose either of these two, calcium channel blocker or diuretic agent, preferably thiazide diuretics. Suppose there is no albuminuria, but the BP is more than 160/100. So in that case, we are starting two agents. So we have to choose two drugs from three different classes. Like that, we have started. Also, we have advice for various lifestyle modifications. Then we will keep on assessing the blood pressure control at every follow-up. So in all these things, if the treatment is tolerated well and the target is achieved, we will continue the same therapy. If they are not able to meet the targets, we have to keep on adding the newer agent from different classes which are not chosen in the initial visit. And if there are any adverse effects, we have to consider changing the medications from different group of drugs. And in some cases, even on two agents, the individual will not be able to maintain the blood pressure within target range. So we can add on the third group of drugs. And even if it is not being controlled with three medications, then we have to consider addition of MRAs, mineralocorticoid receptor antagonist, as the fourth agent. So this flowchart we have to follow. Important thing among this discussion is always look for proteinuria. So if proteinuria is there, prefer that particular drug which will reduce proteinuria. So among these three classes, prefer AC inhibitor or ARB. Okay, the next frequently asked or faced question is that amlodipine will cause pedal edema. So what to do? In that case, you can convince the individuals that it will resolve on its own. No need to add anything else. But if the individual looks worried, you can choose with cilnidipine among calcium channel blockers, or in that case, we need to change the class of drugs to AC inhibitor or ARBs, or we can add on with thiazide diuretics. But if you are willing to stick to calcium channel blockers only, we can change to cilnidipine, which will not cause pedal edema. Now we have spoken about how to initiate therapy and how to monitor, but it is our duty to explain to that patient the benefits of lowering blood pressure, because they might feel just by change in 10 or 20 mmHg of blood pressure, what will be the benefit? It is just a matter of numbers. So in that case, it is our duty to explain the benefits properly. See, the point here is, for every 10 mmHg of SBP reduction, there will be about 12 to 15% of cardiovascular benefits. This the patient might not be able to notice or appreciate, but over long run, this is the benefit of lowering blood pressure. And what about lifestyle? We all know about DASH diet, mainly which will focus upon restricted sodium intake, that is less than 2300 milligram per day, which will account for less than 1 teaspoon of salt for that particular individual. So this one we have to advise practically, and the diet should be rich in fruits, vegetables, whole grains, and they can prefer for 4 to 5 servings of food, vegetables, whole grains, preferably low fat or fat free dairy products, and some protein rich foods as well as healthy fats. So mainly these are included in DASH diet. And according to various studies as well as API recommendation, some other lifestyles like inclusion of yoga and pranayama. As we all know, the breath control techniques in pranayama help in reducing sympathetic drive, which will obviously act as beta blocker, thus helping in effective management of blood pressure. So overall, the lifestyle changes which we have to advise to the patients are like diet. As mentioned, DASH diet should be advised, which will mainly focus on increased intake of fruits, vegetables, whole grains, and restricted salt intake. Alcohol restriction, we have to advise them. Physical activity, it is very important to suggest 30 to 45 minutes of moderate intensity physical activity at least 5 days a week. Preferably here advice for both brisk walking as well as resistance training. And if the individual is having higher BMI, advice for healthy weight loss, sodium restriction, which already mentioned, and smoking, cessation, because all these factors are the risk factors for cardiovascular mortality by their own. So better to not combine all these risk factors so that there will be even more higher risk of cardiovascular mortality. Thank you so much. Hope I have answered most common doubts which we will face during the initiation of antihypertensive treatment as well as during the first visit and diagnosis of hypertension. So if you find it helpful, share it among your friends and also subscribe to our channel so that it will be a great motivation for us to come up with better videos in the upcoming days. Thank you so much.